realignment, and it's the realignment of we called it AB 3632, children that have diagnosis of emotional disturbances, or that program was transferred to the Department of Education. And my question is, and I'm hearing concerns from people, that there has been a vaporization, they call it, of that program, and a lot of those children are not receiving services. Has there been an effort by the state to follow what's happened to those children in that program, the 40,000 children that are in that program? And where are those children now? Have they dropped out of school? Are they getting appropriate care that was guaranteed by the AB 3632 program? Do those children have services equal to the services they received before it was transferred to the Department of Education? And who is monitoring that program to make sure those kids have services for our community? The same amount of money was sent over there as spent last year, correct? But where is that money going, and are those kids getting that service?
Catherine Gaither, Department of Mental Health. I think I was working at Department of Finance when 3632 was enacted, so I probably know far too much about this program. However, the intent in shifting it from the counties to the school districts was to, number one, remove the mandate from the counties, which had been partially unfunded for some number of years, and to return it to the special education program. The services provided to those students are intended to be for them to benefit from an education. The original shift was to create county and school district linkages so that students would get a better mental health assessment and a better linkage to their educational program. Schools at the time, that was a long time ago. I think it was the same year my daughter was born. So about 27 years ago, we're not really providing very significant mental health services in the same way that county mental health programs were able to provide. The funding that was transferred to the school districts was significant, and I think the hope was that the school districts would continue their partnerships with the counties so that the counties could continue to draw down FFP, matching those dollars, which extends them much farther than if you spend them only in one place and not through a FFP eligible program. I think there have been fits and starts. Anecdotally, we hear not much since the program has been transferred, but we have heard through some conversations with counties that some school districts and counties are working very well together. I mean, this isn't a surprise across the California. This is generally the case. Some local entities have very good relationships and work well together, and others do not. So we have heard in many of our stakeholder meetings this summer that there were concerns from some education providers about how the program was being implemented. But this is really properly under the control of the superintendent of public instruction now, and is something that at our department we never had any resources monitoring the program. It was really a county mandate and something that was happening at the local level almost entirely. So I don't have a very good answer for you. I'm sorry.
As far as you know, there's no systematic monitoring of the transition.
I do not know myself, but there may be at the Department of Education. I just don't personally know that. Do you know, Don?
What's happening in your county?
Don Kingdon, CMHDA. There is a monitoring group that has been formed by the Department of Education. There are many county representatives participating in that. My understanding is that they are charged with getting information out to the special education local plan areas and districts as to how this program is to make that transition. I believe they've begun that process of educating the schools. And as Kathy said, what you see when you have as many districts in California, some working very well with their local mental health departments, some going straight to our subcontractors and working very well with them, and then in other places, challenges. Definitely. The bottom line from our perspective, though, as Kathy said, though, this child still has an IEP, individual education plan that needs to be implemented, and we hope parents are being strong advocates for that.
I mean, you think it'd be a good idea to do an audit on that or something like that? Or, I could start getting a heavy-handed kind of approach here. But somebody's got to answer the question, right? I mean, we could do that. We can start.
You may, just again, Don Kingdon, you may want to at least find out what this work group meets like every other week.
Yeah, about work groups.
Maybe
I know
what they're doing.
What's happening to the kids?
I understand.
40,000 of them. Where are they? Are they dropping out? If they drop out of school, which these are the kind of kids that the highest risk kids, they'll probably be dropping out of school. So are they disappearing or out of sight, out of mind?
Jessica Cruz with NAMI California. We sit on the AB 114 transition work group. We have a representative that sits on that work group. We have not heard of any kind of formal survey from the Department of Education of what's happening to the kids. NAMI California, with 3 other parent organizations, did a very small non-professional survey of parent groups that I'd be more than happy to send to you. I mean, the results, again, they're not professional. That was just basically we wanted to survey our parents as far as what they were seeing, if they were getting the help that they were needing. Do they have the skills to be advocates? Did they know that this was even happening? So we have a brief survey, and what we did in that work group is we encouraged the Department of Education to really continue and do a professional survey of not only the parents and whether or not they know that this transition is happening, but also exactly what you're saying, Assembly Member. So we have encouraged them, and I'd be more than happy to send you the results of that survey.
I think the reason why I'm asking the mental health people is if the school districts drop out and give less service, I would predict that these kids will come around and then they'll be knocking at your door and they'll be asking for services. Would you assume that? A lot of those children, and as they, untreated mental health conditions get worse, right? So they come around and.
Don Kingdon, CMHDA, absolutely. I think that we know very well that schools are a very important intervention ground, and we, like the National Alliance, are very concerned about whether or not the schools are able to continue to meet the obligations. I just want to emphasize again, though, from our perspective, they still have that obligation to provide that treatment, in the context of the child's federal entitlement.
Well, I appreciate your questions, Mr. Bell, very much, and I appreciate all the panelists for your contribution here today. And again, not the end of the discussion. We will continue to paw forward in these difficult times and try to make things make the best decisions we can with your help. So thanks. Yeah, I'm going to ask the next panel to come on forward, and I will introduce it in a couple of minutes. I'm taking a 2-minute break, but I'll be sitting up here by the time I come back. Thanks.
Thanks, Will. Yeah, take care.
Test, test.
So our next panel is entitled Mental Health Community Crisis Response, Intervention with Integrity, and we have a case model here in the case of Sonoma County, and hopefully will help to shine some light on some of the possibilities of how local governments can respond to the challenges we face. Tremendous progress has been made over the years with crisis care. Clients, providers, advocates, and state agencies have been working hand in hand to develop new and effective strategies for community supports. This next panel will be discussing the complex array of factors that are critical to recovery for folks with mental illness and the importance of mobile services to respond, identify, and link individuals to appropriate services. And as with the other panels, we're including representatives of clients and families as well. I think that's critical and hopefully will illustrate why this program in Sonoma has had some success. But very proud as a representative of Sonoma County to have you presenting today. We're going to start with Michael Kennedy, who is the Director of Behavioral Health for the County of Sonoma. Welcome.
Okay, I guess it's the afternoon. Good afternoon.
Just ticked the afternoon, didn't it? Yep.
Yes, and I've got the flu, so I might be a little. I'm hoping that I'll sound wise, even though I'm delayed.
Well, so that makes me doubly appreciative that you're here. So hopefully we will be gentle on you.
And it's nice to see you again. You did visit on one of our client-run centers, the Wellness Center, a while back in Santa Rosa. So it's nice to see you again.
I also visited the peer support. I don't know if it's connected to this directly, but the peer support program out on the river out in Guerneville.
Oh yeah, you visited there too, right? Mm-hmm. So we have 3 consumer-run programs in Sonoma County, and Kevin's the director of Interlink, which is downtown. So he'll be speaking about those services. We providing crisis services, mental health, and both for substance abuse and mental health is quite a challenge. It's probably one of the hardest things we try to accomplish. And the only way to do it is with collaboration. So I'm really happy today to have this group with me. Rosemary from NAMI, she's executive director of NAMI. So Kevin, and then our assistant probation chief, Cheryl Lynn, is here too to talk a little more specifically about the implementation of 109 and how we've been doing that. I think one of the things for me, I've been with Sonoma County Mental Health since 2001. I started out there as in charge of the forensic mental health programs, including the jail, psychiatric services, and then the then homeless program, which was AB 2034 in those days. And then I actually volunteered to do the coordination for the Mental Health Service Act. So I actually got to go through that whole process from the community planning through implementation of programs, and then became the mental health director in 2009. And then in 2010, I was given the gift of substance use services also. So I'm now the behavioral health director. So for me, part of the process has been a really robust planning process with the community. And we discussed back in 2005 what some of our choices were going to be, especially around crisis response. And so I'm going to highlight some of those programs. And these are programs that we were able to enhance our service delivery system by the use of Mental Health Service Act funding. So it was really, it's been a great asset to us, and we've really focused on blending Mental Health Service Act funding with realignment funding and with our Medi-Cal FFP.
Well, I think that's important, one answer, not the answer, but one answer to those who have been frustrated that the Mental Health Services Act hasn't been available to train law enforcement officers or to or for involuntary treatment is to, in fact, find a way to address these issues in the kind of collaborative way that you've done.
Yeah, and that has really, I feel like it's had great outcomes, and it's really created an ongoing group of stakeholders that give us input all the time. So we've really tried to build that into our process. Our service, our crisis services really are based. The base of it is our psychiatric emergency services, which are at a site which is in downtown Santa Rosa, and the program is open 24/7. So that's really the basis of where we, law enforcement brings any of the involuntary holds. That's where people drop off. We are right across the street from a medical hospital to Sutter, so as far as doing medical clearance and things like that, we're able to do that. And then we have a consult contract with Sutter Emergency Room, so our staff can walk right down, do psychiatric assessments, and then also we're able to transport people back up to psych emergency services. There we also have the ability for crisis stabilization, which means we can keep people overnight, and we can then, as we're looking for either hospitalization, inpatient hospitalization, or many times people, we're able to work with people, they stabilize, and we're able to get them back to their living situations. The other thing we implemented in Santa Rosa, and this is also with MHSA, is a crisis residential program. So that's a 10-bed program. It's managed by Progress Foundation, and it's really an alternative to hospitalization. It's a house. It's really a beautiful home. It's a great place for people. Most, as we look at, so say in the first 6 months of this year, we saw 1,600 people at our psych emergency services, and out of that group, we hospitalized about 319. Okay, so the majority of people they're able to stabilize, either go home or go to the crisis residential program. The other thing with the crisis residential program is, as people stabilize in inpatient, they may be able to come to the crisis residential program and then go home. We're able to get people out quicker, so we use it as a step-down program, too. The problem with just having a PES, though, from our point of view, and my background before I worked at County Mental Health is for 13 years I ran the Larkin Street Youth Center in the Tenderloin, and our group was runaway teens and TAY all the way up to age 25. And there's no way to force those kids to get services. You actually have to get out there, engage, do outreach, really work with them to engage them in services. So I'm a really big believer in aggressive outreach and engagement. So what we've done is, the problem with the PES is you have to bring people there, or people have to get there. So what we wanted to do is expand that so that we're out in the field. So we've added a number of mobile teams that we feel are really the way to go. And I just want to preface this with, this is what works in Sonoma County. We're a mid-sized county, about 470,000 in population. Santa Rosa is the biggest city with 150,000. These models, you have to adapt depending upon if you're a small county or a place like LA, or, it depends really upon your population. So I want to make that clear, that the model, although you can generalize some of these things, it's different depending upon what county you're in and how much land you're covering and things like that. What we did in our planning process, too, was a little unique, was we invited a number of groups to participate, one including the community college. Community college representatives from the school system, too. As I said, NAMI was there in force with us. And then one of our local Indian Health Project also was involved from the start through implementation. And one of the things we decided to do was a mobile team that works with the community college. So we have licensed staff that actually sit on the crisis team at the college. So by being part of that team, any young people that get referred to the crisis team from the school, we're able to do a treatment planning on and then link the services. One of the things we as we were doing our planning process, we were looking at the reports from the Virginia Tech incident, and we tried to build in some ways that we would make sure we'd be able to link young people at the college directly to either PES or our mental health services, and be able to share information between the community colleges, healthcare center, and us. So that's one thing we implemented. What we decided to do too was, since we were doing it at the community college, we're going to use some peer college students to help us do some training and other things. We decided, let's add in 8 high schools and do a similar mobile team at the high schools.
Can you talk about the CSU, about going to Sonoma State?
We are talking with Sonoma State, and we're hoping we're going to get them involved in the project. Initially, they weren't interested. But I think they're changing their mind because of the success of the program. One of the things that we decided to do, too, was we do this thing called QPR, which is question, persuade, and refer. And it's a nice model to teach students, teachers, custodians, and people in general on how to recognize signs of mental illness, signs of depression, how to persuade somebody, how to question them, how to talk with people, how to persuade them, and then link them, refer them to services. It's a great model. It also has a model that you can do, teach people on the internet. So for young people, it's a kind of a model that can work. And we've already trained, I think, 600 teachers and individuals throughout the school system, and it was so successful at 2 of the high schools that next year at Annalee and El Molino, they've asked us to train the incoming freshman classes in QPR, both incoming classes. So it's a model that we think gets to the issue of, a lot of times families do not know how to make calls, how to link people to services, how to even recognize signs. So it's another way for us to kind of prevent or get the information out. I think I handed you a brochure that we put together, which is a guide for families on how to contact law enforcement if they have an issue. We did this in conjunction with NAMI, law enforcement, and put this together so that gives people something to go by to make the call and get the appropriate action they need, especially when people are sometimes a little hesitant to call law enforcement. The other thing we implemented was what we call the Community Intervention Program, another mobile team which really focuses on homeless. This team goes to all the homeless shelters, all the homeless programs on a weekly basis, and we either do consult with staff or we link people to services. Again, it's that model of getting out in the field, identifying people that need to get further services or link into crisis services, but then also providing consult to help stabilize other people and get them what they need. So it was something when we implemented, my staff were a little worried that we were going to get overrun with referrals, and it's actually worked in the opposite way. I think it's created a lot of confidence at the programs that they're able to handle certain types of behaviors themselves, and really has turned into, we get really appropriate referrals, not inappropriate referrals. So it's really worked for kind of a bi-directional model. The other places we're focused is with veterans, and we've also have a number of sites where we work with the federal qualified health clinics, where we're able to also provide services to some of the ethnic minority populations of the county. At the Indian Health Project, at some of the FQHCs where we're able to really serve large numbers of Latinos who then get their mental health services and their health services at the same sites. So again, it's adjusting our model to try to fit where we think it'll work better in the community. We're also I'm going to move to this slide and then come back. We also, through Mental Health Service Act, implemented earlier, there was discussion about CIT programs, and that's really that post-certified 40-hour training for law enforcement, which is really born out of the Memphis model. And many California...
Training specifically in dealing with mental health intervention situations.
Intensive 40-hour training with involvement from NAMI, from consumers. We have panels. We visit the programs. We have role plays. At the end, that's how you end up. The fourth day is all role plays, and then and it's a post-certified, and it's really a curriculum that's based in this crisis intervention training. Right now, last I saw, stats were there were 69 different CIT programs now across the state. In a majority, many counties now have provide this. We started it in 2008. We're doing one this month and then one in June, where we'll train another 60 officers. Over the past 5 years, we'll have trained now with these two trainings 300 officers across all jurisdictions in Sonoma County. And I think the total number of officers in the county is about 500.
So have you been able to document statistically at all significant difference in outcomes for those kinds of crisis situations where law enforcement is called?
Haven't been able to really document.
I know it's hard to document what doesn't happen, but successes are harder to measure than failures.
We've seen. I would hesitate to link it to certain things, but I think there is some documentation that 5150 calls have decreased. I know there is that from law enforcement, that documentation, and I would say that if you talk to consumers, family members, and our staff, that they can tell the difference when somebody comes up to PES with somebody in the car if they've been CIT trained. There's just a big difference in the way they handle themselves and the way they even interact with staff.
And it gives families confidence to make the call.
Yeah, it does do that. And I would say, we hope to be able to document more with the next phase of that, which is that was the first phase. Now that we have 300 officers trained, the sheriff and the Santa Rosa PD have agreed to work with us now on implementing a mobile support team.
I appreciate the comment about the willingness to make the call, because I won't name jurisdictions because I don't want to create ripples, but I have a number of district offices, and in the Senate, when I was in the Senate, I had more. When I was in the Senate, we had a mentally ill person who had been contacting our office and clearly in distress and in crisis, and we were afraid to call law enforcement because of a history of incidents that had happened in terms of what happened to the people who law enforcement was called. We called the county mental health department, but and the situation was resolved satisfactorily. But that reinforces your point that family members or clients or peers or others may be afraid to contact law enforcement, and the outcome could be very, very difficult. But if there's a greater collaboration, a greater level of training, it seems to me that it solves lots of potential problems.
Yeah. I think it gets to the coordination and collaboration. We're hoping that with the new mobile support team, where we're going to have a team that meets law enforcement on calls. It looks like we're going to be doing it from noon to midnight each day. We took a look at calls over the last over a year's period, and between the Sheriff's Department and Santa Rosa PD, they get about 15 calls a day that are mental health or substance use related. So we're going to be meeting at the sites now on those calls, be there with an ambulance, and then be able to either intervene and take over or work with law enforcement to get people up to PES. We hope, we think that will also prevent that thing that happens when they're trying to bring somebody in, somebody sees the uniform, that it turns into some kind of scuffle. Then the next thing you know, you have a mentally ill client that's in jail, which really needed to just come up to psych emergency services. we're confident that this is going to help that, because we'll be able to be there, and also they'll be able to kind of step back and let us work with the person as long as the scene is secure. So we're really looking forward to that. We're also going to have, as part of the team, we're going to have postgraduate students working with us and some consumers to actually go out on calls with us. So that's kind of a new thing that we're going to try with it. That should be up and running in the next couple of months. We're hiring the staff right now to do that. So lastly, again, I did talk about our crisis residential unit, and then we have coming in May, somebody bought the old hospital that inpatient hospital that Memorial ran out on Fulton Road in Santa Rosa, and they're rehabbing it right now, and they're going to open a 93-bed psychiatric inpatient unit, which will have a unit for adolescents, a unit for adults, and a unit for older adults, and it'll be a regional resource. So again, we'll have a local resource that will help us. Right now we use really Marin General and St. Helena's and several other hospitals. Really hard as far as being out of county for people. It's really hard for families to travel. I think this will be another resource. Again, we feel like it's a private company runs the hospital. That's the way it should be. We kind of feel like we're, as a county mental health department, we shouldn't be in the business of trying to keep people in hospitals. We should be getting them out. So our goal is people go in, as soon as they're stabilized, we get them out right away, and we'll have somebody there every day making sure that happens. So that's kind of the host of services that we have, and I'll pass it on to Sherilyn next to talk about one.
Well, what I love about what I'm hearing is that it's client-centered. You're really focused on the client, not the problem that is being created or alleged to be created, but rather on the client's needs. So, so we're very, very happy to have the Sonoma County Probation Officer Sherilyn Freitas with us today.
Good afternoon, Chairman Chesbro. My name is Sherilyn Freitas. I'm the Deputy Chief Probation Officer, Sonoma County, and I feel privileged to be here today. I was asked to speak a little bit about public safety realignment and Sonoma County's very collaborative approach to realignment. With only 4 months under our belt, I actually believe Sonoma County has a true roadmap to success. Primarily, with funding coming, we believe we have a roadmap that should be emulated in other counties and is a great model for an effective community corrections plan. In order to begin, I won't wait for my PowerPoint. It's okay. We piggybacked off the SB 678 committee that was identified by legislation to start over from scratch. But our Community Corrections Partnership had 14 members. That it was a very diverse group, and I think it's key. I know the last panel talked about the importance of the human services, employment, stabilizing factors, along with the whole criminal justice group and the substance abuse group. And the 7th voting member was selected by the board, or the CCP partnership, and approved by the board to be the director of AODS Mental Health, Behavioral Health, Michael Kennedy. Sonoma County has a lot of strengths on which we built the CCP plan. The first is that we had already done a criminal justice master plan outlining effective programs, studying our data so we knew exactly who was in our population. We also, Sonoma County has a huge initiative on upstream investments using evidence-based and promising practices across all fields. A couple of those that I want to mention is we work with mental health in a forensic assertive treatment team. It's a very effective mental health specialty court that reduces incarceration and provides a lot of stability and support for offenders with mental health disorders. In addition to that program, which has been very successful for many years, we also have an entire other caseload of specialty mental health offenders who are high risk to reoffend. And we have a specific probation officer. And I think for models, you need to select the right probation officer to partner with mental health in these specialty programs in order to reduce dependence on incarceration and hospitalization, and to encourage them to get involved in things. I mean, our current probation officer has them playing basketball. I was invited to a sing-along for Christmas. I mean, those kind of activities, people don't envision probation initiating those things, but with the collaboration we have, it's a very effective model. In addition to the culture of collaboration in Sonoma County, I actually believe that the key to our plan has been shared mission, vision, and values. Is that the way we started the entire planning process was to have key organizing principles, one of which, a lot of counties, I understand there are 58 models of AB 109, but ours was to use of detention beds should be minimized in a manner that is consistent with public safety and the integrity of the criminal justice system. So once you get past the lens of public safety, don't use detention beds. And I think it's a very effective model. In addition, the system and decision should be risk-based. So we are targeting all programming based on criminogenic risk factors and needs of stabilizing an individual, such as housing, benefits, mental health treatment, those kind of factors. And lastly was that research-tested methods should be used as much as practical. So we had an entire data group, and we will be looking at our effectiveness and continuing programs that work and eliminating programs that don't. And I think that's a key factor when we're doing such a major overhaul of a criminal justice system. Here, I can keep going, actually. No, more. I've blitzed through. Are you kidding? He said brief. Keep going. There's the strengths. There's the organizing principles, all three of them. One more. Okay, so our planning process was to utilize 4 subcommittees, and the purpose of that was that you could get participants who have expertise in a certain area and make recommendations to the Community Corrections Partnership. So supervision, obviously, we're having the post-community release supervision people coming out. We have the mandatory supervision people being added. It's a new population. All of them are high risk to reoffend, pretty much. And so strategizing on what the ratio should be, how can we partner with people, and so that was one group. Another one was sentencing, getting used to all of the 1170H sentencing. How will the court implement it with probation? Will we have split sentences? Will people just order the same amount of time? And again, those shared values had an impact on it. I think we're at about a 55% rate of split sentence, which is it's an excellent thing when you don't have a lot of jail beds and you don't want to use them. Michael and I chaired the Detention Alternative Programming Committee, which was the largest. I think we had 17 members. And there's a reason for that, because these people have a lot of needs. And we made recommendations, and I'm actually very proud to say that out of all of the funding that Sonoma County received, 1/3 of it was for programming. That's a very rare occurrence, and in fact, when the average for most counties for mental health was 4%, ours was 13%. And I think that showed the dedication to the need for mental health services. Thanks. So basically, every county is forced with looking at the custody beds. How many beds are you going to need? Will you need to open 1 unit, 2 units? We have not had to open up a new unit, and we believe in a reliance on alternatives to detention. But we put money aside for custody, supervision, and again, programming. And I think the last panel group talked about a day reporting center, one-stop shop. Well, there's one thing about a one-stop shop and that can be detrimental, is that you need to go from the one-stop shop to connect with already existing community resources. So the day reporting center, at the day reporting center, we will have a licensed social worker, an eligibility worker, and a part-time psychiatrist for the needs of that new population. And again, we don't really, after 4 months, know how many people are going to come out to need hospitalization or more severe services. But we feel like we have a base interim plan that demonstrates our dedication to mental health services. Go to the next one. So here was this shows our commitment to what we valued. Programming in custody, we know that these more people are going to be in custody, more people, going into custody can cause mental health issues, let alone having them before you go in. So again, we added mental health staff for in-custody programming. In addition, we added substance abuse treatment. They're going to do cognitive skills training with the offenders. They already have some of the educational component. Supervision, a 1:40 ratio of effective supervision. And then again, we're adding a lot of electronic monitoring so you can have people that need structure and keep them in the community rather than use those expensive detention beds. One of our goals about the realignment plan was to see how much it could match up with our master plan, our criminal justice master plan, because that seemed to be something that all of the board and all department heads really accepted and endorsed. And so all of these factors were in there, and it included a day reporting center for extensive programming in the areas of criminogenic risk factors, targeting high-risk offenders, not low-risk, because that's evidence-based. We use an objective risk assessment tool, and those that come up needing more mental health treatment, we automatically refer to mental health for further treatment and assessment. Again, substance abuse treatment is key. Cognitive skills program are the #1 programming that is effective with the criminal population, so we've already implemented that. Employment assistance at the Day Reporting Center. We will now be connecting with JobLink through Human Services. We'll be offering GED classes. We use a offender need guide to assess what the needs of each individual offender are, and we make referrals based on that. And then again, I would call it an over-reliance on data rather than an under-reliance. Having to add a bunch of, just even how to track these specific offenders, how many have mental health disorders, how many have substance abuse problems, how many have criminogenic needs of antisocial values or dysfunctional families, or all the key components that need to be treated in this population. That's what we are identifying and providing services toward. And here was our commitment with the AB 109 funding. In custody, again, licensed clinical social worker, eligibility worker, and psychiatrist in both in custody and out of custody. And I think that's just a beginning. I have to say, we're not sure who's going to come out. When the offenders are coming out and they're non based on their current offense, but they could have many other offenses in their background, some of these people have significant mental health issues that can require hospitalization and a lot of treatment. That's it. Oh. And so what I want to say about our plan with a key partnership of mental health is that it protects public safety, but it isn't over-reliant on incarceration. It's balanced, it's upstream. It's consistent with our master plan, our criminal justice master plan. And it's consistent with our values, and it fits with current anticipated resources. We have a whole new planning session about to begin should funding be continued and hopefully be increased. So I don't know if you have any questions.
Well, I'd like to thank you very much, and again, say it's nice to have something that's, I know it's a work in progress, but something that offers some optimism and some hope that all of these changes that the financial situation has forced may actually improve things. Not necessarily so much of what's being done right now is taking us backwards, but it is good to hear that. And apparently a very important part of that is the collaboration, and so I'm very pleased to have Rosemary Milbrath with us today from the National Association on Mental Illness, National Alliance on Mental Illness. Thank you.
Hi, thank you so much for giving me the chance and giving us the chance to come here. I know you all are very busy people, and I appreciate it. I'm the director of our local affiliate of NAMI, of the National Alliance on Mental Illness. And while I was sitting here listening to the testimony earlier today, I thought it was like a tale of two cities. This is the best of times. This is the worst of times. We're in terrible budget times. But we know the same glyph in Chinese for crisis is opportunity. We have an opportunity to create something very beautiful and innovative here. NAMI has always thrived on creating opportunity out of crisis. You know probably that NAMIs were formed in the 70s when the state mental hospitals were emptying out into the communities, and there was a crisis of people coming into communities with no community care system. And these groups of people sprang up spontaneously around the nation and later aligned together into a large national organization to ensure that that community care was there. In my own life, a crisis came to me when my son had a first psychotic break in 2002. And that became an opportunity for me to educate myself, to learn how to properly support him and to support myself. I was referred to NAMI through our county mental health department when I called them looking for help. And it became a huge tool for me. I took the family-to-family class. I became a family-to-family teacher. We know that these are evidence-based practices, that if families get involved or educated, that there's going to be a better outcome for the individual living with the mental health challenge. I was amazed at the amount of stigma that I encountered in my community. My son was an educated, talented, wonderful student and athlete, and he was treated one way before he became sick and another way after he became sick. That was the crisis. It was a crisis when we didn't have enough money in our communities for treatment, and it was an opportunity when MHSA came through. As Director Kennedy was saying, we had these planning sessions that started in 2004 that brought the whole community out to plan how we would use MHSA funds. It was incredible how many people came out. The county did outstanding outreach in every segment of the community. Hugely diverse group of people gathered, and we talked about how we could best use this money to benefit clients. There was some talk about Laura's Law from NAMI people. We quickly learned that was a hugely divisive issue and that there were great voluntary and assisted outpatient treatment programs that we could create within our community. And we decided as a community, literally thousands of people, I think overall, were contacted and many hundreds participated. We decided as a community of the ways we wanted to go, which included, as Director Kennedy has shown us, crisis residential, the mobile crisis unit, community intervention program, CIT, client centers, support for families, family advocacy, work with the schools, work with older adults, intensive work for transitional age youth and children. We've been doing that since that time, and I think there's a great outcome. NAMI was getting thousands of calls per year from people in crisis some years ago. That's gone down because I think people are learning how to access services, and they're getting the help they need sooner. Our NAMI is part of a collaborative with Sonoma County Office of Education and 17 high schools. And we go into the high schools with young clients who are living well with their challenge, and they talk to the students in the classroom about what it was like to be in school and be experiencing that first break, what worked for them, what helped from their counselors, from their students. Now, I believe that if we can reach enough people with that message, young people, we're not going to wind up with chronicity. We're going to wind up with people understanding what's happening with a break happens to them and feeling like they are supported. I think in these times, family engagement is more important than ever because we're going to need more volunteers involved in this effort as funds are shrinking. And I want to assure you that as family members, we want to see our loved ones developing their own wellness plans, voluntary plans, and we want them in our communities and able to live with the greatest degree of independence they can and with the most opportunity to be fully engaged with their community, with employment, with volunteer opportunities. We don't want to see people locked up. We want them to have full lives. I believe that we can live lives of authenticity and courage through these times, and we can have a better community. Thank you.
Well, thank you very much for your presentation. And to round out and complete the discussion, we have with us Kevin Murphy, who is a consumer and is manager of Interlink Self-Help Center in Santa Rosa, and we're glad to have you here.
Well, thank you very much, Mr. Chairman. And Senator Chesbro, I want to remember that I was on the board of the network many years ago when you were given an award by the network for being a champion for consumer perspectives and family perspectives. And I just want to take this first moment to thank you for your continued championship of this issue. And I hope it, as you earlier sought more champions in the legislature. There was a lot of success to that. Anything we can do to help, of course, we're going to do. Interlink was formed 15 years ago when a bunch of clients wanted to create their own center. At that time, SAMHSA was trying to find places. This is the federal government's effort to try to create client-run mental health recovery programs. So you can't get that money now, but many, of course, programs like that have been created by Mental Health Services Act around the state. We were also given an additional funding to augment the program. Under the SAMHSA funding, it was pretty thin. There wasn't really enough staff to make it as safe as possible. When I got there 3 years ago, there was a lot of concerns about drugs and alcohol. 60% of the people we serve are homeless. We're right near downtown. The program was started not by people who had been in jail, not by people who had ever, had trouble with the law or been homeless. But 2 years after they started, they kind of looked at each other and said, gee, half the people coming in here are homeless. Because, of course, the self-help movement, the client movement, has always been very non-discriminatory. But now the program is very much more a recovery-oriented focus. We managed to help people understand what the rules are. If we have somebody who is actively in a psychotic kind of condition or really struggling with a lot of needs, we have the programs that Mike's referring to. We work very closely with the community intervention program as an opportunity to get somebody else to take them up to PES. Fortunately, in our program, we're not allowed to transport people. That's a pretty big barrier for a lot of things. And we have served a lot of the people, even while they're in the crisis residential unit, will come to our program during the day and get peer support. And as you well know, I feel like I'm preaching to the choir, Assembly member, but peer support is extremely effective and extremely cost effective. Unfortunately, what I think we have now in California and in much of the country is really a pale visage of where we will get in this paradigm shift in mental health recovery. I think it's important to take a step back and look that we're talking about this huge shift in assumptions, beliefs, and practices that is only now becoming to slowly evolve. Even though it's been many years since the Mental Service Act rolled out, it's very uneven, as you know. When I was the president of the board of the California Network of Mental Health Clients for a while, it was during that rollout period, I think we saw a tremendous amount of initial input from people when it was required to do your plan. Once implementation started, nobody cared at the state. We had egregious issues in the county I was in that were blatant violations of the regulations the State Department had written, and we couldn't get anybody to help us, call us back, deal with anything. So I think the issue that's been discussed, if I may, I'd like to talk about a few of the things I've heard today about how do we help this to happen at the local level is a pretty critical issue. I think you see, not only because of economies of scale, progressive activity in large counties, it's also because those counties have had strong client presence and organization for many years before. Really, many academics credit the client movement, the self-help movement, for driving this shift, this orientation. We are in danger now. Many people like myself who have been concerned about this for years are concerned that we're in danger of everybody co-opting our ideas and still leaving us behind and saying, keep your $10 jobs. You guys are really doing a good job, but really not engaging the process to where we'd like to go. So how do we solve that with 58 counties and no oversight? My suggestion is, I think would be relatively inexpensive, would be to create an evaluation team similar to what's done in Medi-Cal evaluation that would be contracted out to an independent entity that would hire peers, family members, and clinicians to review each county's MHSA plan or each county's mental health plan as a whole. On an agreed upon, we can get people together at the state level and agree upon what those criteria are that really are transformational, that really are making sure we're involving the peer's voice and the family member's voice. At least the people at the local level would then have a tool to go to their board of supervisors and say, this is where we're at. As it is now, the client's voice gets lost. Unless the county leadership, as in the case of Sonoma County, is very aggressive in trying to engage clients. If they're not, there's really very little recourse, and that's with the regulations we had before, let alone what happens in the near future. I think to speak to Assemblymember Ball's question about how do we get more people involved, I started a program in Mendocino County from scratch. When you start a program from scratch, you need the community's involvement. It takes a while to grow leadership in the peer support community. It doesn't just happen. Sometimes clinicians think, oh, peer support, they mean we're going to take the people that just got out of the hospital today and tomorrow they're going to be supporting other people. It doesn't work like that. It takes time. But there are lots of people who have recovered from severe psychiatric distress who are ready now to provide support with just a little bit of training. And identifying those people and supporting the growth of that leadership at the local level is a critical piece. But again, in an age of diminishing resources, how do you do that? That's an interesting challenge I'd like to see us to take on and try to see how it is we could do something more effective about that. Another question is the conversation about outcomes. let's take a step back and see where we are. It's only now that Sonoma County is looking at the ANSA, which is wonderful, which is a measurement tool that says how much are we actually helping people recover. The average person in society probably doesn't understand that we're at that elemental stage, that mental health services have been provided for many, many years without any measurement of whether what we're doing is effective or not. Those kinds of requirements make a lot of sense, but of course it's not a requirement. It's something voluntarily because it's the right thing to do that Sonoma County has chosen to do. Engagement happens best when somebody looks like you, whether it's cultural competency or because it's someone who's been through your experience. There is no problem with a very small amount of money engaging a huge number of people because they're out there. To use the Bible, if I may, the fields are white for the harvest. The number of people that are struggling who will respond to a peer's presence are remarkable. It's what do you do once you have them and engaged? Do you have the array of services for people to find support? Do you have peers in all these positions? 20 years from now, peers will be in primary care settings, in the jail, and everywhere. Why do we have to wait to make that a goal? It's a goal. It's a stated goal in the Mental Health Services Act, but its implementation is radically uneven. So how do we support the growth of local leadership and help them move forward is something that I think is important to consider. It's really a challenge to be the last speaker. After lunch, the lunch gong has long sounded and feel like I have a lot of passionate things to say, but at the risk
your stomach's growling at the same time?
What's that?
But your stomach is growling at the same time?
Yeah, and it's hard to outshout somebody's stomach. I hear that. 20 states, more than 20 states do have Medi-Cal waivers to allow peer support as a billable thing. And Mr. Kingdon referred to something that's going to coming in some years, in the next few years, I believe he said. It would be helpful to accentuate that happening sooner. It doesn't solve the problem of there being a limited amount of money, but it's something that could make, again, a very extremely cost-effective and helpful thing. I appreciate the opportunity to speak to the committee.
Okay, well, I thank you very much. Sitting here listening to you and marveling at the progress that's been made and the collaboration that's taking place reminded me, I hate to even think about it, but and I'm sure some of you were there, that prior to the adoption of Assemblywoman Thompson's Laura's Law, the Speaker of the Assembly and the President of the Senate created a joint committee to hold hearings around the state on the involuntary treatment issue. And Assemblywoman Thompson and I co-chaired that. I was the Senator chair, and she was the Assembly chair. And we held a hearing in Santa Rosa. And at that time, not just in Santa Rosa, but at every hearing we held, the community was badly divided by the issue. With NAMI, generally speaking, I'm generalizing, but generally NAMI over here and the clients over here. And there was a lack of constructive solutions that resulted from the polarization around that issue. It really was an obstacle and a barricade. And, of course, Prop 63 came along, and statewide we saw the realization that there's power in unity and putting aside our differences. And so that, I think, was very effective. And it's one of the reasons Prop 63 is worded the way it is, was to try to build that unity. I'm very impressed and excited to hear about the progress in Sonoma County, not just in getting along and talking to each other, but actually collaborating to put in place alternative programs that can best serve people that are really, as I said earlier, targeted on the clients. And of course, part of it is being driven by necessity with realignment and trying to figure out how to make the best use of resources and the Chinese blessing curse. I guess the one question that I still have outstanding, thinking about what's going on around the state, not just from the standpoint of monitoring client participation and a full, robust process at the local level, but what is the sense of whether other counties are moving in a similar direction as Sonoma County, and are there other counties talking to you about how you're doing it and asking for advice? I mean, is it having a ripple effect or a beneficial influence beyond? It's very exciting to see it in a very important county and one that I represent, but I'm hopeful that it's not completely unique and that, in fact, this is, as Kevin said, there's in the future this is going to be this is going to be just part of the system, but how are we doing in terms of it landing successfully in other counties? This or similar, your approach or similar approaches?
Yeah, I would say, we all, I really take advantage of the Bay Area Directors Group, and we share all of our, different approaches. I think that's a really important part that CMHDA plays in things. And then there's a number of state PEI projects that we're all working together on. Healthcare reform too. Everybody has we're all starting to move to models where we're working with federally qualified health clinics with, to get to not only provide consult and services to people with mild to moderate mental health issues, but to really make sure that our clients get healthcare services and medical care. Many people have brought up that our clients' average death for those with serious mental illness is age 50 because of complicating physical health issues. Our clients need to be in health care. So one of the projects we're doing right now is the federally local Santa Rosa Clinics is going to have a nurse practitioner at one of our mental health clinics to provide healthcare services on site for our clients. So we're doing a lot of things like that. We're also partnering with a homeless clinic that provides health care services and mental health services free to all homeless clients. So, I do think we are. There are several counties that I think are really doing some very innovative things.
But ours is the best.
I like to think so too.
And we really all try to, it's very, we all try to learn from each other. I do think I'm lucky to have such an involved stakeholder groups in my county, with NAMI being so involved. And then besides our consumer-run programs, there's a consumer advocacy group newly formed that works in our county that really is involved in all the things that we're doing, including.
Well, when I served on the Prop 63 Commission, I had what I thought was a brilliant idea, but then the millionaire's tax revenue began to drop, and then the governors began to propose transferring Prop 63 money, so it didn't materialize. But it was some sort of information transfer or sharing of success stories and models. Mm-hmm. Like I thought something like a best practices conference, where you'd have opportunities for people to go and hear, like I've had the privilege of just hearing from you and other counties and what they're doing that has worked and is working and is promising. So one of my the challenges I'll just throw out there is to the commission and to the Directors Association and to the clients and others is for us to think about ways that we can learn from each other's experience, especially where there have been the kind of collaborative success stories that you're developing. And I'm as much as I agree it's the best, I'm certain that there are other good stories out there that we need to figure out how clients and communities and providers and jurisdictions can benefit from each other's experiences. So, but this is a very optimistic discussion, and we don't have enough of those these days. So I'm really pleased that you were willing to come over here and provide it to us, and it'll certainly help inform mine and hopefully the legislature's continued work on these issues. So, thanks.
Thank you for having us.
Sure. My pleasure. And now we were at the public comment portion of the agenda. Did we get the sergeants? I think the sergeants have sign-in cards. Did we have anybody who signed up who wanted to address the committee? Or if there's not, then I'll just call on folks to come on forward and talk to us. If you could give us your name and if affiliation, if any.
Yes, good morning or good afternoon. My name is Stacy Hiramoto. I represent REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And REMCO represents not only the Asian community, but also the Latino community, the African American community, Native American communities, and other communities such as the Muslim communities and others. Thank you for giving us the opportunity to weigh in. When you first started to talk about bridging the gap and what have we missed, we have to talk about mental health disparities. And one of the overarching goals of the MHSA was to reduce disparities, but all indications that we have currently with what little data we have is that sadly disparities still exist, and frankly they are not getting better. So I think that is something that you really need to remember. You talked about people were talking about that the OAC is now going to do oversight. Well, as far as the evaluation goes, I've gone to the evaluation committees. I don't feel that reducing disparities is something that's a priority and being measured. It may be measured slightly, but again, I don't believe it's a priority. So what we are worried about is statewide oversight. We're very concerned about that in general. But I will get to specifics because I know it's at the end and I don't have very much time. I do want to really commend the Department of Mental Health for keeping the Office of Multicultural Services. We are concerned about certain things. For example, part of it is going to one department and part of it is going to another department. However, they are to be commended for keeping things such as the Cultural Competence Plan requirement reports. That is one of the few ways that people can really see what counties are doing, and we are so happy that they are keeping that. We're also concerned that the chief position, one of the reasons that the state's Office of Multicultural Services was so strong is because the former leader of that office was in a chief position and had direct access to the director of the department. They have downgraded that position or either gotten rid of that position, and so the person heading that office, although is doing a tremendous job, is hampered by the fact that she does not have that same rank. And you know in state government how these ranks and access to the director, and so that concerns us greatly. But again, we want to commend the Department of Mental Health for their idea about the $60 million that was set aside and promised for the Reducing Disparities Project and keeping that at a state level. That I know is supported by all the strategic partners in the California Reducing Disparities Project, and I will tell you all the ethnic and racial and cultural communities support that it stays at the state level and not go to the individual counties, because we cannot ensure they do not have good track records, I'm sorry to say, in working with the ethnic and racial communities. And so in order to see that project retains the promise of developing programs and approaches that needs to stay at the state level, and hopefully with the Office of Multicultural Services. So thank you again. I'm happy to talk to you later and for giving us this opportunity.
Well, I welcome your input, and as I've indicated to others who are on the panels, it will be very valuable to be hearing that input as well in the budget subcommittee process, and I'm assuming that we will be hearing from you or your peers. Thank you.
Hi, good afternoon. I'm Joseph Robinson with California Association of Social Rehabilitation Agencies. CASRA is a statewide association of private, not-for-profit, public benefit corporations that provide services to clients of the California public mental health system. We were especially pleased to hear community crisis response discussed at today's hearing, as we believe that addressing this item alone can have a positive impact in the lives of those with mental illness, and is a way to recognize significant cost savings. For example, the use of crisis and transitional residential treatment programs, like the ones mentioned by Michael Kennedy in Sonoma County, can link non-hospital urgent triage centers with acute diversion programs and are critical to addressing the high cost of hospital and other institutional 24-hour care. But unfortunately, these programs are often overlooked. This was quite evident in the recent mental health and substance use needs assessment submitted to the Department of Healthcare Services. This report stated, quote, "Analysis of inpatient psychiatric beds suggests there is an adequate supply as well as maldistribution of these beds in the state," end quote. This finding focuses solely on psychiatric hospitalization, and it implies that the solution is to make more psychiatric beds available rather than focusing on the scope of alternative services for those in need of acute psychiatric care and support. Until there is acknowledgement that psychiatric hospitalization is but one treatment option for those in need of acute psychiatric care, other more cost-efficient alternatives with better treatment outcomes will be grossly underutilized. Thank you.
Really appreciate your comments, and ditto the other earlier comments about the importance of you communicating with the Budget Subcommittee as we move forward in dealing with the governor's budget proposals. Yes, sir. Welcome.
Thank you, Mr. Chairman. My name is Dylan Studi, and I'm a resident of Sacramento, and I can tell you that the subject matter of this committee in several areas is very near and dear to my heart. I just have a couple of inquiries of you, if you could. The issues that you've discussed during this hearing, have you looked at a way to connect them to how they relate to people with physical disabilities as well?
Well, yes, they do relate to. I mean, this is a select committee that has oversight over the whole area of disabilities, and so we are very concerned with physical disabilities. And I'd be interested in hearing what you have to say about how the issues connect and relate to each other.
Are you looking to convene a future hearing on the subject?
Well, our last hearing was on developmental disabilities, and I don't know specifically what area of physical disabilities you may want us to address, but I'm open to your suggestions.
So you'd be interested in receiving written testimony from me and possibly granting me a seat at the table at some future date?
Yes.
Thank you.
Yes, very much so. Thank you, and I appreciate you being here. So anybody else want to address the committee before we close it up for today? If not, I want to thank everybody who participated. We face a really challenging time. There's going to be a lot more discussion of all of these issues going forward. You've helped me and Mr. Bell and other members of the committee whose staffs are watching to inform our approach to responding to the governor's proposals and to the needs of clients, particularly, and also of their loved ones and others who care about them. So it's very valuable that you have shared your time with us today, and I want to thank you. And with that, I'll adjourn the meeting. Thanks.